Yay! Okay, excellent. Okay, phew. Just had a false start there. All right, welcome everybody. We are here tonight talking about young onset Parkinson's disease. And I did this because I was so inspired by how many of you reached out to watch my previous mini lecture on Parkinson's disease, specifically the non-motor symptoms. And we had about 25,000 people watch that video, which was really, really exciting. People from Egypt, from New Zealand, from Australia, from England. It was really, really exciting. And it just confirmed to me how awesome the PD community is, that you guys are out there really wanting good quality information, that so many people are very motivated to do everything that they can to ensure the highest quality of life for either themselves or somebody that they care about. So what I wanted to do was take our talk about PD to another level by trying to think through the differences between young onset and older onset, or what we call idiopathic Parkinson's disease. And that's typically what we think of, the image that we all have in our minds when we think about PD. But tonight what we're going to be focusing on is young onset, and typically that is people who've been diagnosed from the age of 21 to the age of 50. Most Parkinson's patients get diagnosed when they're about 60, and that in between of 50 and 60, I would say I actually have quite a few patients that fall into that range. I do pre-deep brain stimulation evaluations, neuropsychological evaluations, and a lot of those folks that I see are between 50 and 60. So that's kind of interesting, because do you fall into the young onset or do you fall a little bit more into the older onset? That's not really clear. But what I wanted to do tonight was talk about the top 10 unique factors of young onset Parkinson's disease, so that way you all can understand more uniquely how this brain health issue is unique and challenges you. I wanted to introduce myself a little bit more clearly because we have so many new viewers. We have about 700 likes at this point, which is fantastic and makes me feel so good that you all are out there appreciating what it is that we're trying to do with this program. My name is Dr. Dorothy Sullivan, and I am a board-certified neuropsychologist, and I practice in Pinehurst, North Carolina. And what I care about is brain and behavior. We are scientist practitioners who are master diagnosticians, and we pride ourselves on putting together a personalized care plan for the people that we see. I started the I Care for Your Brain program last year when I just got sick and tired of hearing people talking about these fads in the brain fitness industry, supplements, brain games that were pretty expensive but really have no return on your investment. I knew that there was a whole giant field of brain health science that was out there that brain scientists know, but just isn't well communicated to the general public. So I do a series of things in my community to try to spread the word on brain health, but it occurred to me a couple months ago that if I did this on Facebook, I could probably reach a whole lot of people, and it's completely free. So I love those two things about it. So why don't we get started by talking about our topic tonight. About 10% of people are diagnosed with PD between those ages of 21 to 50, and that's the research that we're going to be talking about tonight. There are some younger onset juvenile Parkinson's-like syndromes that are diagnosed, but typically we think of 21 to 50. What we're going to talk about tonight are the similarities of young onset PD and older onset PD, but we're really going to focus on what are the significant differences. The first difference that I want to talk to you about is that the journey to diagnosis is much different for the younger onset patient. And part of this is because when you go to a doctor and you are 30, you're 40, you're 45, Parkinson's disease isn't necessarily the first thing that comes to their mind, where if you were 70 years old and you went to your doctor, that's very normal jump in their clinical reasoning. They would very well think maybe this is Parkinson's disease. So people with young onset actually take much longer to get diagnosed, and the journey to get the diagnosis is often a long and windy road. Many people get misdiagnosed as having things like arthritis, leg cramps, anxiety, different kinds of physical disorders until they get to the point where they see a specialist and they're properly diagnosed as having Parkinson's disease. We know that for all types of PD, whether it's young onset or older onset, there are no biomarkers, there are no blood tests. There are a few very sophisticated neuroimaging programs that you can get injected with a radioactive dye, and we can look at how dopamine is taken up by different parts of your brain. But really, it's much more of a clinical diagnosis. So the doctor has to understand how this starts, how it's progressed over time, the kind of things that might make your symptoms get worse, the things that might make your symptoms improve. And if you don't understand Parkinson's disease, these things aren't going to mean as much to you. Many times people who come in with young onset PD are complaining of things that are a little bit general. So not so much the tremor issues as more stiffness. You know, my shoulder just doesn't kind of quite feel right. So a lot of people get misdiagnosed as having sports-related injuries. We also know, this is my number 2 point, that the symptoms of the very first stage of Parkinson's in young onset is different than it is for the older folks. In the older folks, it's pretty typically a unilateral tremor, an overall slowness of physical speed, mental speed, more shuffling of people's feet, a little bit of a stooped posture, some of the masked face symptoms where people find the musculature in their face is just a little bit more tight. For younger people with PD, dystonia tends to be the very first symptom, specifically after exercising. And most people with young PD, well, I shouldn't say most, I should say a good proportion of people with young PD actually get this kind of an arching in their foot. That's the very first symptom. And if you go to a doctor and you tell them that that's your problem, a lot of times they'll say, well, maybe it was a muscle cramp. Let's get you some muscle relaxers. But for many people, this is actually the first symptom of the PD. The mean diagnostic age is 44 for young onset. More men than women are diagnosed with it, and significantly more Caucasian men are diagnosed with PD. The number 3 thing that is unique is you're much more likely to have a family history of Parkinson's disease if you have the younger onset. We think about a quarter of people who are diagnosed with young onset have a known family history. Of course, you can also have an unknown family history where there's plenty of people that you either don't know in your family, or maybe it goes past 2 generations and you're just not aware of the different health challenges that they had, but they know that when they do genetic studies and they're able to get back to people's lineage, that many times in young PD there is a genetic component. With all brain health issues, a general rule of thumb is the younger you are when you first start to express symptoms, the more likely it is to be genetic. One of the things we're going to talk about in a little bit is this interaction between our genes and the environment, and how so many brain health issues are thought to be a result of people having a predisposition genetically to developing a problem, but something in the environment turning on that gene. And that is what we care so much about as neuropsychologists, is what are the modifiable things that if people only knew how to do better, they would, and maybe their chance of getting a brain health issue would not be as strong. We know that there have been several genetic mutations associated with young onset PD that have been identified. This is not something that generally happens in the course of someone's workup, but typically if there is a very strong family history and someone is very concerned about the likelihood of passing on, specifically one of these juvenile or later childhood versions of PD, there are about maybe 5 or 6 different genes that they can do genetic testing on for. The one that I read about most commonly is called Parkin, PINK1, SNCA, GBA, and something called LRRK2, LRRK2. If that's something that is concerning to you, again, the younger you are when you start to develop PD, the more likely it is to be genetic. Those are the genes that you're going to be screened for if you go in for genetic counseling. The number 4 unique factor of young onset PD is that the progression of the symptoms tends to be much slower. And that is actually contrary to many other brain health conditions where the younger you are, it actually gets worse faster than if you were to get it in older adulthood. Alzheimer's disease is the perfect example. People who unfortunately get diagnosed with young onset Alzheimer's disease have a much steeper cognitive and functional decline than people who get diagnosed with young onset Parkinson's disease. And one of the reasons we think that is the case is that the younger brain is much more likely to be able to engage in the mechanisms of neuroplasticity, that when there is an area where there's a problem, another area is able to come in and either compensate through active strategies that the person is taught how to do things a little bit different, or the other parts of the brain are able to, on a chemical level, kind of come in and give a helping hand. People who are younger with PD also tend to participate and commit to the physical therapy treatments that we know are very, very helpful in this condition. We also know that as people are younger with the disease, they are getting different medications, which is maybe the most important thing that I'm going to share with you tonight is, I think it's my number 6 or 7 important factor that's unique to young onset PD, and it has to do with the use of levodopa. So we're going to get to that in a minute. But what we know is that the only non-motor symptom that is more prevalent in the young onset PD are restless legs and sweating, but most scientists agree that this is a medication effect and not something that is uniquely related to the Parkinson's. So of all the non-motor symptoms that I talked about 2 weeks ago, it actually seems that the young onset folks aren't as susceptible to these cognitive symptoms and to as much of the anxiety that we tend to associate with PD. Now, in a minute, we're going to talk about how the adjustment process is very different for younger folks, and it seems to be more difficult. Quality of life issues are harder. But in terms of the biological contributions to the mood symptoms, we don't see it as much in the younger folks. So that's, I think, pretty good. This one here is really, really important because this has very real-world consequences. I think we all know that levodopa is the gold standard, so-called gold standard treatment for Parkinson's disease. And the idea is that it's administered in a perfect world in the later stages of the disease. We know that levodopa is a purified form of L-Dopa, which is a precursor of the catecholamine problem that happens in Parkinson's disease. But the problem is, since these catecholamines, including dopamine, don't just affect things like tremor, we see a wide effect across the whole body. And if you remember last time, we talked about this as being related to some of those non-motor symptoms. So the idea is that the younger you are, the earlier you start to get your levodopa, the more likely you are to have some of these undesirable side effects. And the 2 big ones are motor fluctuations and dyskinesia. So motor fluctuations are basically on-off phenomenon. If you have PD, you know exactly what I'm talking about. The availability of dopamine in your brain is not steady all day long. One of the biggest challenges, especially as you get more used to the medicine and as PD progresses, my patients tell me, is that there's always this feeling of kind of waiting for the meds to kick in or waiting for you need the next dose of the medication, because you can really feel when you're on, and when you're off, you're going to have more symptoms, you get more of the freezing behaviors, you get a little bit more of the rigidity. So this is going to happen more and more the earlier you start to take levodopa. And this is really, really important because if you get your diagnosis from a primary care physician or even a neurologist that is not a movement disorder specialist, sometimes their first instinct is to put someone on levodopa. And this is why so many of us advocate for people to go to movement disorder specialists, because there's a lot of high-level information that is very important that your Parkinson's disease doctor understands, so you don't have this unfortunate thing happened to you. Now, of course, everyone is different, and I have a lot of respect, of course, for physicians and for neurologists, but I think the truth is that you or someone that you care about deserves to be evaluated by an expert, somebody who bread and butter is Parkinson's disease, not someone that sees a lot of different kinds of folks with a lot of different kind of medical conditions. One of my biggest things I want to encourage you to do is to get out there and to advocate for yourself or a loved one, to see the very best medical specialist for your problem that you can possibly see. It's just very, very, very important. So this finding has led a lot of movement disorder specialists to do something called the Dopa sparing strategy. And what this is that they're basically going to hold back on adding in that levodopa until it feels like it's absolutely necessary to minimize these side effects. But when you look at the research, one study showed that 83% of general neurologists, not movement disorder specialists, but just general neurologists, prescribe levodopa to their young onset patients, whereas the movement disorder specialist had a totally different strategy. The principles are very, very simple. The idea is to avoid levodopa for as long as it is practically possible and to limit its use whenever necessary. So they're using alternate drugs, different types of approaches, in order to postpone that point to where they start to introduce the levodopa. Most physicians, like I said, who are not very familiar with PD have never heard of this before, and you would completely shock them if you said, you know what, I understand the gold standard is we're trying to actually postpone my use of the levodopa. I think they're very well intentioned, but they just don't know the data. So this is why you gotta get yourself to a movement disorder specialist. Number 6 is how the adjustment is unique and different for people with younger onset PD. Why do we think this is? It's probably 2 different things. The first one is that people are at a very different social time in their life when they get diagnosed with young onset. And we all have schemas or ideas in our mind about what it is we should be doing at any given time in our life. So when we're 50 years old, we expect to be working in a job that is meaningful to us, that maybe our children are a little bit grown, that we're thinking about retirement in the next couple decades. The idea of having a progressive movement disorder is usually not in the forefront of most people's mind. So it's unexpected. The second thing, of course, is that the future is somewhat uncertain when you have any kind of brain disorder, but specifically one that you hear is progressive, that gets worse. It's very hard to prepare for a future if you don't understand exactly what's going to happen to you. That's just human nature. We all want that sense of control and that sense of predictability to say, I know what's going to happen to me as I get older. Now, of course, it's somewhat of an illusion because none of us are guaranteed anything, but we all get a lot of unconscious comfort from the idea that we can imagine ourselves in the future as an older person and what it is that we are going to look like. The minute you get diagnosed with something like young onset Parkinson's disease, it's a whole different picture of what it is you're going to look like when you're older. And the research tells us that this really causes a reduction in some people's quality of life, and it can make people feel more depressed and more anxious. And this is why it's really, really important to me that you will consider incorporating a counselor or a neuropsychologist into your care team. I'm going to get to that in a minute. The other thing is that many people are contemplating having children or grandchildren around the time that they get diagnosed with young onset PD, and there's a lot of concerns about the genetics. Sometimes even feelings of guilt. You know, I don't want to have passed this on to my children. This is going to be devastating to me if this is something that my children have to deal with when they're older. So there's just a lot, I think, in terms of the mental adjustment that goes on. But my experience is that that's not really being talked about when you go to the neurologist. These aren't questions that are readily being asked. You know, how are you coping with this? Do you find yourself getting very anxious? Are you worried about what the future holds? Are you worried about what it is your children might be facing? We kind of focus so much on the medical side and on the physical side that I really feel that there is a real lack of acknowledgement and intervention that's going on with more of the mental health side. The other thing is that we can get very focused on, and I feel like I understand this as well as I can, about why. Why has this happened to me? There is so little information that is known about most of the brain health conditions as to that environmental piece. What happened to me? Okay, yes, I have a family history, but it's not that strong. I had an uncle or I had a second cousin, and I keep reading that something must have happened in the environment that turned on this gene. With PD, a lot of what we think about is occupational and chemical exposure. The problem, though, is this is not information that is readily accessible, and a lot of people aren't aware of what the science is saying about what different chemicals maybe prompt the expression of the gene. And I'm really excited to tell you what the focus of our next week's lecture is going to be when we get to the end of today, because it involves this very issue. So I thought this was really interesting, that a little bit of the history here. So for decades, brain scientists knew that there was something in the environment, but it really wasn't until the 1980s when intravenous drug users started to be studied by epidemiologists that they started to maybe think about how Parkinson's was related, because some people were getting Parkinsonian symptoms and syndromes after using IV drugs, and specifically being exposed to different kind of methyl drugs. So this led to a whole line of research, but think about it, I mean, it only goes back to the 1980s. That's really not that long ago, and this is part of why it's so important that we put money into research, because if this is something that's going on in our environment, specifically as it relates to chemicals that are in our food, I think this is a public health crisis. This is something that we all need to be thinking about. Most people, when they think of chemicals in Parkinson's, think of things that cause it, but there's actually some chemicals that have a protective factor. That research has shown us that when people are exposed to certain chemicals, they're much less likely to develop Parkinson's, and those two are nicotine and caffeine. And I bet you didn't know that. I think that's very interesting. Agent Orange, of course, is probably what we all think of when we think of one chemical related to Parkinson's disease. Exposure to Agent Orange in Vietnam related to Parkinson's is one of the few things that the VA system considers to be a service-connected disability. So they've readily admitted that the two are related. But beyond that, we really don't have any chemicals that are thought to be the culprit. There's definitely a lot of research, though, that talks about different classifications of chemicals. So chemicals for insect infestation, exposure to herbicides. One study looked at a couple of hundred people that were diagnosed and looked at their previous history, and I wanted to go over some of their findings because I would want to know this if I had young onset PD. First one was a history of living in a house that had been fumigated for rodents. The next one was rural residency at the time of diagnosis. So this is basically living on a farm where you're probably exposed to a certain amount of pesticides. Eating nuts and seeds before the age of 10 was positively associated with a diagnosis of young onset PD. And like I said, the protective factors were cigarette smoking and caffeine. So this certainly lends some strength to the theory that all versions of PD, whether it's young onset or older, are related to exposure to something in the environment. Number 8, I think, is very important to remember, which is that even though we're making this distinction between young onset and older onset, the truth is we're all different, and we have to make sure we treat every person with a brain health challenge uniquely. And yes, we need to understand the basics of how does PD tend to affect most people, but we never, ever, ever want to come at people with a rubber stamp of what they need and how they need to be treated. So it's very important for me as a neuropsychologist to remember that every single day, that I try to bring my general expertise to people that I meet, but also remember that people have a lifetime of experiences that have nothing to do with Parkinson's. And so we can't let someone's whole identity become wrapped around this idea of having PD. Of course, it can consume you, especially when you're seeking information and you want to be educated and you want to do everything that you can. But as a psychologist, I also want to encourage you all to remember that there's many other aspects of your identity. And I think that people who do better from a mental health standpoint try really hard to keep in touch with other aspects of their life that aren't related to their movement disorder. Number 9 is to advocate for what I call the gold standard care team. First and foremost, I really would love you all to have a movement disorder specialist in your corner. I understand that not everyone has access to that, but if you live anywhere near a metropolitan area, I really want you to seek out someone with expertise in Parkinson's disease. The other thing is that I want you to expand your idea of who it is that should be on your care team. And I think that a neuropsychologist should be on there, and a counselor, and a physical therapist. You really need expertise from a lot of different disciplines in order to live your very best life, especially when you have the younger onset of these neurological disorders, because especially with PD, we know that if you can stay involved with the physical therapy, if you can delay those levodopa medications, if you can make sure your quality of life stays strong, that the disease progresses slower. You're not as likely to have some of those non-motor symptoms that we talked about 2 weeks ago, and that the depression and the anxiety that is so commonly associated with older onset PD, statistically at least, doesn't seem to be as much of a factor for this subgroup. So we want to make sure that it stays this way and that everybody who has the chance at the highest quality of life possible gets it. Number 10 is that I want to encourage you all to learn everything you can about young onset PD. Now, of course, you did yourself that favor by listening to me tonight. And I want to follow up in next week's lecture by dedicating the whole time to these environmental chemical exposures, because I think that so many of you are rightfully concerned. And I want to go through all the literature and help you understand what is it that is being written up in these brain health journals that scientists have gotten so much public funding for, which makes me feel like it's your right to know the results as someone who's paying for this with your taxpayer dollars. But also, maybe this is information that you can then use for your children, for your grandchildren, to make sure as much as possible that you limit their exposure. I don't know a lot about that finding where eating nuts and seeds under the age of 10 was associated with PD, but that's the kind of thing I would like to know more about. So by doing this as my topic next week, I'm going to give myself the opportunity to do some more research and to really find out all that I can. We know that there's been quite a few reviews that look at this issue. Most recently, one was done in April 2016. So I'm going to make sure that I bring that to you next week. That is all I have for tonight. I want to thank you guys so much for watching. It means so much to me when I see all of you sharing this video with people all over the world. It makes me feel so grateful for the opportunity to sit here and to share my knowledge with you. My number one hope is that it eases suffering in people who might not understand what they're going through because they just haven't been told, or maybe it helps someone get better care because their caregiver was watching this. And the more people we let know, the more suffering we can reduce together. So thank you guys so much, and stay tuned next Wednesday. Take care. Bye-bye.